everyone. Good afternoon. Okay, so I'm here at work today, and I just wanted to check in briefly because I said that we would talk about breast cancer screening this week. So I just wanted to go ahead and get started. Thank you guys for joining. Thank you so much. Thank you guys for joining. I appreciate y'all for being here. So I don't know if I'll have the full 20 minutes today. I'm here working, but I did want to touch base because I promised that we would talk about breast cancer screening today. So as you guys can see, welcome, good afternoon. Good afternoon. I'm wearing my pink in honor of Breast Cancer Awareness Month. And this is a month when we recognize that it's important for women to get screening for breast cancer, and we also honor and celebrate all those who continue to fight against breast cancer. And so I'm going to go ahead and get started with those things. We're going to touch base on basically 4 things that I want you to know in terms of breast cancer screening, okay? So let me just introduce myself again. Hi, Sean, thank you so much for being here. Hey, Malum, hey, son, thank you for being here. I appreciate you guys for being here. Thank you. And so, again, today we're going to be talking about breast cancer screening. So I am Dr. Madeline, your board-certified OBGYN, international speaker, and published author. And what I like to do is I like to help women access the GYN care and birth control needs that they have so that they can have the most freedom and control of their lives as possible, okay? And so, today, as we've been talking about for the last couple of weeks, we're going to go ahead and discuss more details about breast cancer screening. So again, it's October. It's the time of the year that we celebrate and we honor and pay respect to breast cancer screening. And so I wanted to make sure we covered just 4 things today, okay? And I'm going to try to touch base on all of those things. Again, hopefully I don't get paged before we're done. But 4 things I want you to know. So the first thing is there are 3 major sets of guidelines that have recommendations, formal recommendations in terms of breast cancer screening on mammograms, okay? So we're going to talk about those 3 sets of guidelines. 2, we're going to talk about the main type of mammogram that's done for women. Most women these days have a 3D mammogram, so we're going to talk about that. 3, what things make you high risk, and what are some things you need to keep in mind or possibly do different with your breast cancer screening if you're high risk. And the 4th thing we're going to talk about is the fact that there are some racial and ethnic disparities that exist and what those mean and how we can try to fight against them, okay? So first thing to keep in mind, and this is important because sometimes I'll have patients who'll say, hey, Dr. Madeline, you know, one physician or clinician recommended this for breast cancer screening, someone else recommended this, and so which one is right? How do we know which one is the right thing to do? And so just to clarify, there are 3 main professional organizations that have recommendations about breast cancer screening, and it's important that that we talk about them because all of them are right. All of them have looked at data. They all have different groups of professionals and experts who've looked at these things, and so their recommendations are based on what each expert's opinion is. And so there's one group, the American Cancer Society. They recommend that women get screened starting officially at age 45. However, they do say that from age 40 to 44 that it's important that you have a one-on-one conversation with your provider so that you can make a shared decision about whether or not you would like to have that screening between ages 40 and 44, okay? Then there's the U.S. Preventive Services Task Force. They actually have the recommendations that start the latest. They say women should start having mammograms by age 50, and that between age 40 and 49, that a woman again should discuss that one-on-one with her provider, and then they come to a shared decision. Now, ACOG, or the American College of Obstetricians and Gynecologists, that's the body that most of us OBGYNs go by, and actually a lot of physicians go by that one. That one says that you have your initial mammogram no later than age 40, and then every 1 to 2 years until age 50, and then again, you always have that ongoing conversation with your provider. That conversation is important because if you ever feel something different, Like let's say you're doing a breast exam, your own breast exam, and you palpate something different, then you may not want to be one of those people who waits until age 50, like some of the recommendations do say. Hi, Colleen. Thanks for joining. I appreciate you being here. Okay, so those are the recommendations that I wanted to discuss. If you're at increased risk, which we'll talk about in a minute, then those change a little bit, okay? The second thing, most mammograms these days are done using 3D mammography. That's important because the 3D testing is a little bit better because compared to 2D, because they're able to see more of the tissue, and you have less things that are obscuring the view for someone who's having the mammogram done. Okay, so that's important to keep in mind. That's also important because not every place that you might get your mammogram has the 3D offering. And so if you have your mammogram done at a place that does not have the 3D offering, it's important to understand, what that report might mean when it comes back to you. What we have found is that when women are able to get the 3D offering compared to the 2D, they have less callbacks. And so I don't know if you guys remember, it used to be very common for some women to have a mammogram done, and if it was done in 2D, they would get a note in the mail or a call from the radiologist or something that says, hey, we need you to come back in and have another study because we need to repeat the test, or something is obscured and we're not exactly sure what it means. And so that happens less with a 3D mammogram. Now, so when you go and get your mammogram, be sure to kind of like ask. A lot of places, again, have a 3D mammogram these days, but I want you to make sure that you ask so that if something pops up, you'll be able to know which one you had. If your insurance company gives you a hard time, they're doing less of that these days because most people are approving 3D mammograms. Just make sure you clarify and that you know which one you had so that you can advocate for yourself. Okay, so that's the second thing I wanted you to know. The third thing I want you to know is which things might make you high risk and how does screening differ if you're high risk. So the things that might make you high risk when you are with your provider in the office, if you have a parent, a mother or a father, because breast cancer does happen in men, it's less common, but it can happen in men as well. If you have a mom, a sister, a brother, or a daughter or a son who has developed breast cancer, then that puts you in a high risk category because that's a first degree relative to you. If you have a family member who had or has breast cancer and you go ahead and get tested and you end up being positive for the BRCA gene, BRCA1 or 2, then that puts you into a high risk category, and you should definitely be screened a little bit differently. If you have let's see, if you've ever had radiation therapy, let's say you're between age 10 and 30 years old, and for whatever reason you had radiation therapy to your chest, maybe you had something that appeared to be a tumor or it was some type of treatment that you were having done, then it is important that you consider yourself high risk. So what does it mean if you're high risk? Your screening recommendations, they start a little bit younger. So instead of waiting until age 40, if you had a first degree relative who had breast cancer, then you would start your screening 10 years before the age in which they were diagnosed. So what does that mean? If your mom had breast cancer at age 41, then you would have your initial screen by age 31, because you would want to know 10 years before your first degree relative developed theirs whether or not you had any signs or anything that may be of concern. Okay, so that's one thing to think about in terms of whether or not you might be at high risk. So when you are considered at high risk, yes, you have a mammogram, but most times we also do an MRI with those patients to really get a clear picture of what's going on. And so yeah, that's another way to think of it when you are high risk. Hi, Dr. Zakiba, thank you so much for being here. So that's the third thing I want you guys to know. The fourth thing I want you guys to know is regarding racial ethnic disparities. So breast cancer certainly doesn't discriminate. It affects all women regardless of racial ethnic background. What we know for sure is that it is diagnosed more commonly, or it can show up definitely more commonly in white women. However, for Black women, for Latinas, for Native American women, breast cancer is diagnosed later in the course, and women of color also die at an increased rate compared to non-Hispanic white women. That's important because when they look at the data and they try to figure out what's going on across the board, one of the things that unifies women of color when it comes to having more severe breast cancer and also dying sooner is related to access to care. And so it absolutely matters if you have insurance. It absolutely matters if you have some type of coverage that can allow you to get into a provider's office earlier or sooner so that you can be evaluated, so that you can get the care and the referrals and the recommendations that you need. That's important also because I want you guys to think about, when you hear these discussions about health insurance and whether or not you might be for or against health insurance, think of it in terms of that as well. Think of it in terms of our sisters being able to access the things they need so that they can be healthier for longer and also get surgery and whatever intervention they might need earlier compared to later. Whenever we're talking about cancer, earlier diagnosis, earlier access to treatment, those are always things that are going to be better for a woman. Okay, so again, let's recap. And again, I thank you guys for being here. I see some of you guys are along the top as well. So the recap is this: breast cancer screening, 4 things to know. What is the first thing we talked about was that there are 3 major sets of guidelines. There's American College of OBGYN, there's American Cancer Society, and there's the U.S. Preventive Services Task Force. The one that most physicians go by is the ACOG, American College of OBGYN. And that means that most times your provider is going to recommend that you get your first mammogram by age 40. Okay, that age 41 is considered a baseline screening mammogram. One thing I want to add, because I didn't say it earlier, it is actually, research is not yet guaranteed that doing a self-breast exam or a clinical breast exam is going to do as well as a screening mammogram. That's important to keep in mind because, a lot of times, yes, when you come for your annual exam, your provider will do that breast exam. But the most important thing that we find in terms of women and breast cancer is that if a woman does do her own exams, even if she doesn't do them regularly, if she does them to know what her baseline is, then if her baseline ever changes, if she feels something different or new for her, hey Lee, thank you for joining, then she can always let her provider know so that she can go in, get evaluated, and just get checked out to make sure everything's okay. It might be if she feels something, sometimes we start directly with a mammogram, other times we start with an ultrasound. It just depends on what's going on and how high our index of suspicion is in terms of something going on. Okay. The second thing, just to summarize the 4 tips. Oh, we have a question here. Do men get mammograms or do we need to? That's a great question, Malum. Right now, there's no routine recommendations for men getting mammograms. Because again, they're rarer in men than in women. But I would say that if a man has a first-degree relative, that man should absolutely be screened. So if a man has, a father, mother, sister, or brother who has, they have had breast cancer with a close person in the family, then absolutely that man should consider getting a mammogram. Again, the age for that man would be 10 years younger than when that first-degree relative had it. I would say, especially if it was a father, okay, a male relative. So again, the 4 things to know. 3 sets of guidelines. I want you guys to always keep in mind the ACOG guidelines that talk about your first baseline screening at age 40. The second thing to know is that I want you, the ladies and the men, if there are any who are watching who might get a mammogram, I want you guys to keep in mind the 3D mammogram. Ask if you go to get your mammogram this month, especially this month when everyone is having screening, ask if it's a 3D mammogram that you've had done. If it's not and they call you back for a follow-up study, be sure to ask about 2D versus 3D. And if you can get to a place that does 3D, that's going to give you a good assessment of what's going on. Oh, one thing I forgot to mention, because one of the things that my patients continue to complain about, and it's normal, a lot of women dislike the fact that the breasts have to be compressed when we do the mammograms. That is because we want to try to get the tissue as flat as possible, because if there is something that's noted, the flatter the tissue plane is when we're doing the mammogram study, then the easier it is to not have other tissue obscuring. And this is absolutely the case when there are women who have larger breasts, but it's the case when women have smaller breasts too. When breasts are larger, there can be dense tissue, and when they compress it in those metal plates, it's not to cause pain. I have some patients who come in and they're like, I think they just made that mammogram machine to torture us. It's not to torture us. It's really because they need to see the tissue as clearly as possible so that we can detect if something is there. Mammograms look for, you may have heard of, sometimes people call them microcalcifications. Those are usually areas in the breast that are too small to palpate. So even when we do the clinical breast exam, the microcalcifications are areas that we are probably too small for us to palpate when we do a routine exam in the office, okay? So that's one reason why that compression happens. We know it's uncomfortable. The 3D machines are have made it a little bit better so that they compress, yes, but they can usually get fewer films, so they don't have to keep on compressing in different positions. I have a patient who, many patients who have asked about, you know how the dentists now, they have the big machine that just kind of goes around so they don't have to do all the other stuff. I hope they're working on something like that. I'm not sure yet though. But if one of you guys knows how to, you know, if you're an engineer and you can think of something that would just kind of circle around the breast and not have to require the compression, absolutely go for it. But we are not yet there. And so, again, 3 sets of guidelines. 2, most mammograms are done using digital 3D. Be sure to ask your provider which one you're having done. 3, the things that make you high risk: first degree family relative, parent, sister, brother, child. That's a first degree relative, okay? If you have done a screening and you have the BRCA1 or BRCA2 gene, that also increases your risk. And again, your screening should start earlier than age 40. A lot of people say by age 30, but again, it's 10 years, it's officially 10 years earlier than the age of whatever first degree relative you might have that had it. So again, if they had something at age 31, then you get your screening at age 21. Okay, and the 4th thing to keep in mind is that racial ethnic disparities do exist, and they are in large part due to differences in healthcare access, with women of color in this country, Hispanic Latino women, Black African American women, Native American women, they're disproportionately uninsured or underinsured in this country, and so disproportionately they access care later, and so we tend to have be later in the disease process at diagnosis, and also women of color die more. Again, breast cancer does not discriminate. It impacts white women as well, but again, it's women of color who are diagnosed later and therefore don't do as well with their prognosis. So I thank you for the questions that I've had so far. I don't know if you guys have any other questions. If you do, please feel free to put them in the chat box now. So far so good. I haven't been paged away yet. And if you don't have a question now and you think of one, you know, either after this talk has ended or later in the week, please be sure. Oh, we have another question here. Are there any issues on the ballot this November that impact the health disparities for women of color? Absolutely, absolutely, and that is a great question. The Affordable Care Act, when it was signed into law in 2010, it absolutely and positively disproportionately helped people of color, because again, I just said that people of color in this country have disproportionately less access to health care. We are greater numbers in terms of who's uninsured. Hey Renee, thanks for joining. Thank you, Colleen. And we're disproportionately uninsured. We have more challenges in terms of accessing care that we need. So absolutely, voting this November is important, because one thing we know for sure is that the current administration is actively trying to kill the Affordable Care Act. And as far as we know, there's nothing that they have planned to replace it. And so if you think about the fact that, yes, the Affordable Care Act is not perfect, but it's brought us a long way from where we were before the Affordable Care Act. And so we had more people who were uninsured before the Affordable Care Act. We had more people who were in severe medical debt before the Affordable Care Act. So again, it's not perfect, but I think let's work on it and tweak it and strengthen it where it needs to be strengthened and not kill it altogether. And so yes, this November, when you are choosing your candidate and voting for your candidate, make sure you understand what their plan is in terms of health care. A candidate who plans to try to either maintain what's there or strengthen what's there, or even work on something that's going to be even better is the candidate that I would go for. The current administration, as you guys can see in the news, is trying to not only take away what we currently have, but they don't have a plan to replace it. Okay, and so that's how I would answer that question without giving you the specific names of who I plan to vote for. But there are, for me, there's a ticket that clearly is in support of supporting women's health issues, supporting women continuing to have access to reproductive health care, whether it be, mammogram screening, pre-existing condition, or even being able to still support your children up to age 26 years of age, or access to birth control, all of those things. There are candidates who clearly support those things, and that's who I'll be voting for in November. So thank you for that great question. Thank all of you for your attention today. Remember, this is Breast Cancer Awareness Month. If you meet any of those categories that we talked about, age 40 and above, or if you're high risk and you meet some of those other categories, please don't forget to get your mammogram done. You don't have to have it done in October, but if it's been a year or more since you've had your last one, ladies, then, give a call and get yours scheduled. I've actually scheduled mine for, I think, another week or so, and when I go in and get it done, I'll be accountable, and I'll share that with you guys as well, just as some encouragement. So again, this is Dr. Madeline, your board certified OBGYN, international speaker, and published author. I help women access GYN care, especially birth control, so that they can have what they need to live a free life and be in control of their circumstances as much as possible. Please be sure to follow me on Facebook, Instagram, and Twitter at Dr. Madeline MD. And so with that, I'm going to sign off, and I will come back next week and we'll talk again. Thank you so much for being here. Okay, have a great Sunday. Bye-bye.